start recording the session, and I think we should go ahead and get started, Amy, and then a few people may join a little bit late, and that's fine. So I will just begin by saying my name is Jillian Hopewell, and I'm the Director of Education and Professional Development for the Migrant Clinicians Network. And we're pleased to be able to present this webinar to you. It is accredited for both continuing nursing education and continuing medical education. So we just ask that you, at the conclusion of this session, that you fill out an evaluation, and that will let us know. There are some folks, so people are calling in. We normally don't have it where people can call in and have the audio. So for those of you who have called in and are part of the phone system, if you could just make sure that you mute your line when you're not speaking, that would be great, because it just gets distracting. And then for folks who haven't called in and are just listening through their computer, we also really want you to participate by, and you can do that through the chat room. So Amy, I'm going to turn it over to you and let you.
Well, welcome. We have folks from Migrant Health Services. This is Amy Liebman. I'm talking to you now from Maryland, and Matt Kiefer is calling in from the National Farm Medicine Center in Marshfield, Wisconsin. And so we're excited to be back with you virtually. And we also have on the phone with us two folks from a Community Health Partnership in Illinois. And so the idea of our presentation today is that we're basically a sort of part two, a little bit more in-depth with a focus on pesticides. So we're picking up where we left off with each entity. And we're hoping that you will participate, ask questions, participate in the poll, stop us. As Jillian said, it's a new format for us, having people call in. And the idea was that we don't have a huge national audience. We have our two partner health centers, and we're hoping to make it as intimate as possible in terms of being able to actually talk to us. So this is just letting you again know that we are CME and CNE accredited, and in order to get your CME and CNE accreditation, you'll need to fill out the evaluation that will be sent to everyone who registered for this. And Matt and I never have anything to disclose, unfortunately. We wish we did, but we don't. Occupational health doesn't pay well. And so the objectives for today is that we are looking to offer you ways to better recognize signs and symptoms of pesticide overexposure. We're hoping to introduce you to some tools and resources to assist you. And then the last objective, identify clinical policies or procedures for pesticide emergency preparedness. We're just going to touch on that when I talk about a resource that we have, but it's something that we will continue beyond this webinar to work with you in developing specific policies and procedures for your clinics. And the other thing before I hand it over to Matt is one of the main resources that we're introducing you all to today is the 6th edition of the Recognition of Management and Pesticide Poisonings. And I'm hoping, and I'm not sure, that most of you have a copy in your hands, and if not, there's a PDF available online. If you don't have this book in your hands as we move forward, that is fine. Just know that when one of the requests for this training was that you wanted resources, know that this is the resource. And with that, I'm going to hand it over to Matt and let him just tell you just a really brief history about this book and why it is the resource that clinicians do need to have accessible to them when looking at pesticide poisonings.
Yeah, nice to meet you all. Matt Kiefer. I'm the director of the National Farm Medicine Center and an internist and occupational medicine physician with past history of having been a professor at the University of Washington in public health and medicine, having worked at the Yakima Valley Farm Workers Clinic as well as the Downtown Occupational Medicine Clinic at Harborview for almost 20-some years. Anyway, my particular area of interest has always been agricultural health and safety with a focus on pesticides. And I saw a lot of pesticide poisonings both in Nicaragua, where I worked for 2 years, as a pesticide epidemiologist and instructor, and also at the Yakima Valley Farm Workers Clinic, mostly not acute, mostly chronic, but saw some acute cases as well. So we're going to talk a little bit about using this book, and we're going to talk a little bit about diagnosing pesticide poisonings and some tricks that I've learned over the years about various pesticides, and so we'll go through some case studies. The Recognition and Management of Pesticide Poisonings is in its 6th edition, and I have to say I've seen this, I think, probably since the 2nd edition. I don't think I've ever seen the 1st edition, which was really just a pamphlet done by a guy named Morgan at the University of Iowa, one of the early pesticide researchers in the United States, actually predating the establishment of the Environmental Protection Agency. He was working in the area. But he wrote the first, second, and possibly the 3rd versions, but it's just steadily improved and expanded since that time. And really, it's a tremendous resource. And Jimmy Roberts and Rout, who are the 2 people who put it together, both did a great job on it. And Jimmy now is firmly in charge of the last 2 editions, and he's really doing an excellent job. And I encourage you to use the book if you can. If you have an opportunity, look through it at least and familiarize yourself with it. Okay, why don't we go on to the next slide. There you go. Okay, so we're going to talk a little bit about a case. This is an individual who presents to your clinic with headache, nausea. He's vomited a couple times. He feels weak. He's pretty hot and sweaty. He's just come out of the field. He's fatigued. He is afebrile, and he hasn't reported any seizures. Amy.
For some reason, folks are saying that you're going in and out. I'm hearing you perfectly fine, but some folks are having a hard time via the computer. They're having a hard time.
Okay.
Bill, any thoughts?
No, I'm hearing it fine too. So there, oh, good. And now Ty Woodley said that he got on via the phone. Let's proceed forward and just let us know if you have any, if you have trouble. We'll see what we can do.
Yeah. Carrie Brennan just sent out an email, folks, and it's on the chat box. If you wanted to call in via the phone, it might be easier than hearing on the computer, and our apologies. Okay, Matt, go on.
So this individual presents to you, and he's been working in an apple orchard. Let's go ahead. Next slide. On your examination, you find the following. He's really sweating a lot. When you look at him, he's got his shirt off, and because he's sweating, he's a rather thin fellow. You can see the muscle fasciculations under his, on his pectoral muscles. You also note that his pupils are quite constricted, and he seems a little bit confused. He's just not completely square on for somebody who who's doing what he's doing. So
I got him on the phone, but I can't get on the computer.
If you're on the phone, you need to mute your line.
Go ahead and next slide. So what do people think this looks like? Does anybody have any idea? I can't see the chat boxes, so you'll have to read them to me, Amy.
Well, we just opened up the poll, so you should be able to put in there what you think it looks like if you're on the line there.
And do we have to go to the next slide to see the poll?
Nope. Are you not seeing the poll there, Matt?
No, all I see is what do you think this looks like?
That's weird. I wonder why you're not seeing the extra pods. But I'll just read it to you then. So right now we're at 50-50. 50% of the people think it's a cholinesterase inhibitor poisoning. And now we've changed, that's 60 now, and 40% say methyl bromide poisoning.
Okay.
So we'll close it there.
All right. Yeah, that's not even coming up for me, the poll.
Yeah, it's not.
At all.
Sorry, Matt.
That's weird.
Okay. All right. So so what we can do then, if we use the book, we can go to, if we have some signs or symptoms that we can work with, we can actually go into the book and turn to page 244, which is the start of the index of signs and symptoms, and we can start looking up some of the things that stand out. And so what are the things that stand out in this particular case? Obviously, the the guy's profusely sweating, so that's one thing that we should think a little bit about. But one of the really unique things about this guy's exam is he's got these virtually pinpoint pupils. You ask him, he's not using any narcotics. He obviously hasn't had a brainstem stroke. And so what you've got there is you've got a constriction of those pupils that are beyond normal, and so you look up to see what constricted pupils might represent, and you use the table. And the two that come up are organophosphates and N-methylcarbamates and nicotine. You can ask him, has he been smoking? Has he chewed tobacco? He'll report no. And would he have been exposed to a nicotine-containing pesticide in the field? Very unlikely. There are some pesticides that do contain nicotine, and the neonicotinoids emulate nicotine stimulation, but have not been connected to pupillary constriction. But instead, the two that really look suspicious here, particularly because of the sweating, are the organophosphates and N-methylcarbamates. So that's where the money looks to be right now. So where do we go from there? Next slide, please. So we could turn to page 43 and look up the organophosphates, or go to the N-methylcarbamates, so we familiarize ourselves with what we're expected to see. And one test we can do for measuring whether or not maybe this individual has had a cholinesterase inhibitor overexposure is a cholinesterase test. And that, I should point out, is one of the very few tests that we have available to us to make the diagnosis of pesticide poisonings, is the cholinesterase test. There's virtually no regularly available tests for most of the other chemicals that people might be exposed to, save for the anticoagulants where you could get a PT. But generally speaking, this is the one you can get. You might not get it right away. There are some quick tests for this and quick kits that you can have available in case you're in a place where you see a lot of overexposure. And you can get these and actually have them in your lab, and you can do the test very quickly. But most of the time you have to send these out. So cholinesterase, you have two choices. You can do plasma cholinesterase or red blood cell cholinesterase. And let's say we did red blood cell cholinesterase, and this is the level we got. So we got a 9, so it's in the normal range. So we got a guy who looks like he's got a cholinesterase inhibitor overexposure, but his cholinesterase results is still in the normal range. So what do we do with something like that? Well, one of the things, if you look at the literature, about a 50% depression in cholinesterase is going to give you a pretty toxic individual. So a sudden depression of 50% is likely to give you a pretty significant illness. And so if he's at 9, what else might we think about here? Let's go to the next slide and take a look. Does this really rule out an OP just because he's still in the normal range? Does it rule out an organophosphate poisoning? My answer to that would be one thing or another, but I think we have a poll to find out, don't we?
So Jill, are you going to do the poll?
I'll pull it out, yep, and then we'll I'll let you know what folks say, Matt.
All right.
So the poll is open. You should be able to see it.
So what does the poll ask this question? Does this rule out OP?
Mm-hmm. Yep.
And
it's yes, no, or unsure. And at this point, 100% of folks who've answered are saying that it does not.
It does not rule that out. Okay, very good. So let's go to the next slide then. And we don't see any level at all. Are we getting a level here? There we go. Okay. So in fact, if this patient's normal cholinesterase is up around 17, he could have about almost a 50% depression and still be within the normal range. So that's one of the foibles of the cholinesterase test, is the test done at the moment of exposure or immediately after exposure doesn't necessarily tell you what you need to do, what you need to know. One alternative you have in situations like this, though you can't do it immediately, is to get a follow-up test. And if you do a follow-up test, you can see that the cholinesterase recovers if it was depressed. And cholinesterase, RBC cholinesterase, recovers at about 0.8% per day. So you You know, in a week you'll see some change. In a month you'll see a lot of change if you've had a substantial depression. So that's one way you can confirm it, but that's not going to help you right now. So you're going to have to go with what you think is going on right now, possibly finding out more about the pesticide that the person might have been exposed to in order to make a determination. So let's go on to the next slide. So one other thing that that could happen in a situation like this, we have true depression of a normally high cholinesterase level, which might have been the case in this individual, but there's another explanation for a cholinergic syndrome from a pesticide that does not show up as a cholinesterase inhibition. Now, do we have another poll?
No, this is just more of a rhetorical one, I think.
Okay. So let's go on to the next slide then. Well, let's talk a little bit about what you're going to see in a classic organophosphate carbamate overexposure, a cholinergic syndrome. Meiosis, very characteristic, pupillary constriction. And remember this, that if you see meiosis, you've got only a couple options. You've got somebody who's either used glaucoma treating medication for their glaucoma, and that can cause meiosis. You can have senile meiosis or senescent meiosis, which happens pretty commonly, particularly in light-skinned people with light eyes, but they usually don't get real tight like what we saw. And then you've got the possibility of a narcotics overdose, and you have an antidote for that, Narcan. And then you've also got the possibility of a brainstem stroke, and if the guy's walking into your office, that's not likely to be the problem. And then the last one is a cholinesterase inhibitor, and we do have an antidote for that. So this should be leading us in the direction of a very, very quickly we're going to be able to do some actual therapy. But meiosis is one of the classic presentations. Diaphoresis, the fellow is sweating a lot. Salivation, oftentimes they're salivating and they're lacrimating. If they've really had a big dose, they may have uncontrollable urinary bladder emptying. Defecation may happen. They usually have abdominal pain, and oftentimes they have emesis. And that's because of all the cholinergic activity that's going on. So MD sludge is one of the ways that you can remember this. Go ahead to the next slide. So let's take a look at one of the other things that might cause a cholinesterase normal or a relatively normal cholinesterase in a clear cholinergic syndrome, and that would be N-methylcarbamates. And the reason that the N-methylcarbamates might cause something like this is organophosphates bind to cholinesterase irreversibly. They go through covalent bonding with the sulfhydryl group of the active site of the enzyme. And so they inactivate cholinesterase permanently, and only with the replacement of cholinesterase from the body, with the replacement at the blood in RBC cholinesterase or from the liver in plasma cholinesterase, do you see a recovery of that level of activity. Whereas N-methylcarbamates is a competitive inhibitor of cholinesterase, and as a result, when you take a blood sample of N-methylcarbamates and you dilute it out and you send it into the lab, they dilute it there, you may actually have complete or near complete reactivation of the cholinesterase, and you'll see no significant depression in cholinesterase. And as a result, this is one of the explanations for a cholinesterase normal cholinergic crisis due to a pesticide. So that's one of the other things you got to consider here in this situation. In either case, let's go to the next slide. This is a little bit about the toxicology of N-methylcarbamates, and it talks about the way it causes the parasympathetic overflow. Go to the next slide, please. That's on page 56, so you can read up about that there. And here's where it talks a little bit about the fact that a falsely normal or near normal level can be seen of cholinesterase activity in a cholinergic crisis from methylcarbamates because of that reactivation. There is a method to measure cholinesterase that has been inhibited by N-methylcarbamates and get a true measure of the level of cholinesterase inhibition, but it's a unusual test. Very, very few labs do it, so you usually have to find a research lab to do it. It's a radionuclide based test, and so it's rarely done. Next slide, please. So at this point, what we've got is a cholinergic crisis. We see this going on in the patient with the pupillary constriction, the diaphoresis, the nausea and vomiting, the confusion. So one of the things we can use is atropine because atropine is the primary dose, the primary drug that will reverse cholinergic inhibition. But remember, it's not going to reverse all the symptoms. It's not going to reverse nicotinic symptoms. It's going to reverse muscarinic symptoms because atropine only works on the muscarinic receptors. And as a result, you'll reverse the salivation, the lacrimation, the pupillary constriction, but you're not going to relax, you're not going to release the effect on the nicotinic receptors at the voluntary muscle. So you'll still see some fasciculations going on there, but the person will certainly be feeling better with controlling some of these secretions. Go ahead, click it again, Amy. So here's the dose of atropine for adults and children. But how do we know that we've achieved atropinization? There's a couple ways to do that. And one of the things I would recommend is this, is when you use atropine, use it maybe your milligram or half a milligram to start off with. If you see early atropinization, slow down because atropine itself is quite toxic in large enough doses. In a normal person, if you give them a half a milligram of atropine, you're going to see pupillary dilation, you're going to see tachycardia, you're going to see dryness, you're going to see a lot of the symptoms of early atropine toxicity. But if you've got somebody who's got cholinesterase inhibitor on board, you're likely not to see very much effect until you're getting into higher doses, to 1 to 2, maybe 3 milligrams. So you may have to keep dosing that person up until you start to see some of that atropinization. Okay, next slide. So what are we looking for in atropinization? What are the signs and symptoms that suggest we've achieved atropinization? So which of these on this list, we'll show you a list for a poll, which of these does not suggest atropinization? Go ahead. Next slide.
Matt, while folks are answering, if you look to the top right of your screen, you should see this little icon that has 4 arrows in 4 corners. And I believe your screen is on full screen, which is why you're not seeing the other boxes.
Okay, I just clicked on that, and you're right. It's come up.
Okay. Okay. So you should be able, do you see the poll results now?
Right, I do. So 100% of people say pupillary dilation does not suggest atropinization. Amy, are we giving correct information at this point?
Yeah, this isn't a pre and post test. This is just to sort of ask these questions so you can tell them the right answer.
Okay, so the right answer here is actually bronchospasm, because pupillary dilation is a classic presentation of atropinization. Belladonna, which is the plant from which atropine comes, was named because that plant created pupillary dilation, and pupillary dilation was considered to be a characteristic of beauty in Italy. As a result, Belladonna got the name Belladonna, which is beautiful woman. So just remember that pupillary dilation is very characteristic of atropinization, and that bronchospasm actually is not characteristic of atropinization. Go back to the, can I see those options again?
Jill, I don't, can you see them?
No, I
Yeah,
can't.
for some reason I apologize. For some reason the thing is not.
Okay.
Let's see.
Okay.
Wait, we're back.
No,
We're back. Sorry.
Now, so mucous membrane dryness. Yes, absolutely. You'll dry somebody out with atropine. Facial flushing. Yes, there is a facial flushing that's pretty characteristic. And then blurry vision. Yes, people do get blurry vision. Let's go to the things that help us remember the signs and symptoms of atropinization. Next slide. So blind as a bat. Absolutely. You lose control of your crystalline lens, so you can't focus. Red as a beet. Yep, you flush. Absolutely. Next. Mad as a hatter. If you give them enough, they'll get crazy because atropine can cause chemical psychosis. And then dry as a bone. Absolutely. They get real dry because you've dried out all their mucous membranes. Do we have anything else there? I think we got one more, right? Hot as hell. They're really hot. They feel hot. They're flushed. And so those are the things you can remember. Blind as a bat, red as a beet, mad as a hatter, dry as a bone, and hot as hell. So those are the
toxins. It's showing up on yours for some reason, but there's a nice flame for you guys to all visualize.
Okay. All right. Boy, we are really being plagued by technical problems.
I know.
We're seeing it, Amy, here in Chicago. We're seeing it. I don't know.
Okay, there it is.
So
well, today in Maryland, it actually is hot as hell, so.
Okay, go ahead and click that again. Looks like you didn't get my corrections in this. So go back one. So one of the other things we have to ask ourselves at this point, is there anything else we can do? Atropinization is going to correct, as I said, the muscarinic symptoms of cholinergic inhibition. However, there's the nicotinic receptor, the nicotinic, which is voluntary muscles. Those are not, you're not going to reverse that with atropine because they don't act, atropine doesn't act on nicotinic receptors. So one of the options would be, of course, for the person to smoke a cigarette, right? Well, no, not really. You don't actually want to stimulate the nicotinic receptors because they're already being overstimulated by that excess of acetylcholine because of the inhibition of cholinesterase. So instead, what we have is a drug called 2-PAM, or oxime. Pralidoxime is another name for it. And this particular chemical competes with the organophosphate for access to the active site of the enzyme, thus prying off the organophosphate and reactivating the cholinesterase. So before the cholinesterase can go through that, the cholinesterase organophosphate complex, before it can go through the change to a fully covalent bond, if you give 2-PAM, you can sometimes reactivate that cholinesterase, and that'll help clear up some of the acetylcholine excess that's present in the body and decrease some of the nicotinic receptor symptoms as well. So that's an option. You shouldn't be using 2-PAM in carbamate exposures because of that competitive reactivation that's happening all along. You don't really need 2-PAM in this case. You just sort of have to keep them treated with atropine until the carbamate is cleared. Okay, go to the next slide, please. So we can read about this on page 59. It talks about using atropine versus not using atropine in organophosphates and carbamates. It'll talk about that later in the carbamate chapter. But atropine is oftentimes effective on its own, and many places will not have pralidoxime or 2-PAM around, but everybody's going to have atropine around. Next slide, please. The most important thing you can do is decontamination. And decontamination, if it's the gut, decontamination with activated charcoal, or decontamination of the skin. If it's a dermal exposure, if it's a respiratory exposure, you really can't do much about it. But respiratory exposures are actually a little bit rare because you usually don't get enough aerosolized organophosphate or carbamate in order to cause illness. So decontamination is critical, and as you see, the person doing the decontamination is fully protected. And that's pretty important when you're working with somebody with a cholinesterase inhibitor or any pesticide on them. You don't want to yourself get exposed to it, so be very cautious about being sure that you're protected. Next slide, please. So we've treated them with atropine, we've decontaminated them, we've stabilized them. Are we done yet? Is there anything else we have to do? Do we have a poll on that or not?
No poll.
No poll. Okay.
No poll.
So in Minnesota, this is a map that came off of the website of the Migrant Clinicians Network, and the Migrant Clinicians Network, as you'll see at the end as well, we'll reinforce at the end, has a lot of great resources on it. But this is one that will tell you, do you have to report a pesticide poisoning in the state you're in? And in Minnesota, it is not required. It's optional. It's optional to report any pesticide-related exposure. So in Minnesota, it's not required. In Wisconsin, it's required. In North Dakota, I believe it was required. Was it not, Amy?
Correct.
Yep.
And if there's any question, this is one of another key resource for all of you is this map that's on our website. So
in Minnesota, it's not required. It's a suggestion. And it's probably a good idea if you can do it. I don't know how HIPAA deals with voluntary reporting. I think that's a little up in the air, in my opinion, whether you can report on something that's not required reporting. In any case, you could call poison control because once poison control is engaged, then they become a co-provider, and you can share personal identifiers and personal information about the individual. And oftentimes, states utilize poison control to collect data on reportable events or suggested reportable events. And certainly EPA is going to be regularly accessing that data, so it'll be helpful for EPA if you can just go into poison control.
So
we have a
it looks like somebody had a question here.
One general question is, how much do you see at our small clinics versus in the ER? For example, do we not carry atropine on site, have a decontamination shower, but ER is right next to our clinic? So the question is, how much do you see? I think the ER is usually the place you're going to see most of it. But we periodically saw it at the Yakima Valley Clinic, people coming in with milder symptoms. If they were severely ill, that wasn't the case. And a decontamination shower is oftentimes a special setup. So you might have to bring them over to the ER if you have to decontaminate them.
And there have been a couple of cases across the country, Matt, where folks have wandered into the clinic and clinics were unprepared and sort of set up spontaneously. I know that pesticides exposures are different than they were 20 years ago, but it's not an unusual or unheard of thing that happened at other health centers.
Mm-hmm. And the treatment at the clinic versus the ER, I don't know that I can comment on that. I think it depends on the intensity of your clinic and what kind of setup you've got, how close to an ER you are. I don't know if you can intubate in your clinic or do anything like that. It's pretty uncommon for people to be that sick coming into the clinic, though. They're usually in an ambulance when they're brought in. So what are the following things that we can do to confirm a carbamate overexposure? Would an EEG help us? Would clothing help us? Would EKG help us? Nerve conductions, would those help us? And urinary metabolites? How's our polling doing?
Can you see it there, Matt? We have a couple people are getting in there. You're not seeing the poll?
Not seeing them. I can see the poll, but I don't see the results yet on my screen.
Oh, I apologize. I didn't have the right. Now you should be able to see it.
Oh, okay, there it is. Okay. Okay, that's a good choice. Clothing sample for toxicology. Yeah, in fact, that is a good choice because you can take clothing oftentimes if the person has the clothing that they were exposed in and send it into the laboratory and have it tested. Now, urinary metabolites is also an option because oftentimes you should grab a urine, and we'll talk a little bit about that later, but it's also an option to grab a urine and freeze it. One thing to keep in mind is that pesticides are excreted quite rapidly. So within about 48 hours, you've hit the half-life for the excretion of most metabolites of pesticides. And so if it's two or more days out, you might not be able to find anything. Okay, next slide, please. So these are the kinds of things that we're now suggesting for collection, particularly if you don't know exactly what you're dealing with. One thing is you want to get the label or safety data sheet if you can obtain it. That may or may not be available. There may or may not be anyone at the other end of the line when you call the farm. Possibly a copy of the pesticide application record would be helpful if you can localize where the person was and exposed. Grabbing 10 cc's of whole blood anticoagulated and chilled is helpful. 5 cc's of plasma, again anticoagulated with heparin. You might be able to get either your cholinesterase off that. In some cases, certain labs can test for the actual parent compound in blood and urine and in plasma. Urine, this is something that I strongly recommend, is to get a urine sample and freeze it, and then find out whether you can get it tested for metabolites. And contaminated clothing. Get some of the clothing that the person was wearing, put it in a plastic bag and freeze it. This is one of your most reliable sources of confirmation because you can usually send this to the extension services who routinely do assays on pesticides in the field to determine whether or not coverage is complete. And they can usually, if they don't do it themselves, they can usually refer to somebody who can get it done. Now, this is not going to help you with your diagnosis, obviously, but what it will help you with is confirm the confirm what you thought it was, and it may be very helpful from a medical legal perspective later on. Other things that you can do are fingernail residues, saliva samples. There are a couple assays for saliva, pesticides in saliva, a hair sample if you don't have contaminated clothing, and a skin wipe with an alcohol wipe put into a container and frozen can also be helpful. Okay, next slide, please.
And also, this is on page 27, as Carrie pointed out, but we also, in part of your resources that are getting sent to you at the end, we have a whole form for you for all this, with all this information on it.
And both in the chapter, in the book there, you'll see it, and then the information sheet you'll see as well there on the slide. On page 57, it gives some recommendations for the list of things that we've talked about. Go ahead to the next slide, please.
Are there any questions at this point that anyone has?
Okay, why don't we go ahead and move on? Okay, so this is a young lady who presents to the clinic. She presents with what she thinks are her seasonal allergies. She says early in the spring and pretty late in the fall, she oftentimes has a couple days where she's just really bothered by this redness of her eyes and coughing and sneezing and irritation. She says this usually happens when she's out in her garden. She's cleaning up things and getting the soil prepared for her planting. So it's actually quite early, and it strikes you a little odd that this woman is suffering from what sounds to be like an allergic pollen-like reaction at a time during the year when it's possibly there isn't much pollen out there. It's pretty early in the spring before things have started to bud. So let's go ahead to the next slide. So you're a little suspicious to start with, and you ask her, well, might something else be going on here? And she says, well, I suppose. You ask her where she lives. She lives out in the country, and it turns out she lives next to a potato field. So you look up on Index of Signs and Symptoms. Conjunctivitis is one of the things she complains about. You take a look for that, and you find conjunctivitis there under the eye symptoms, and you circle that in your book, and you realize, boy, there's a whole lot of chemicals that do this. There's all kinds of chemicals that cause conjunctivitis, and she isn't directly exposed to any of those that you can see, but a couple of them are things like chloropicrin, which is a fumigant, as well as acrolein. That's a fumigant used sometimes.
Okay. No, this is just one, and I'll be back. Well,
If you're on the phone line, can you just make sure that your line is muted?
Yeah, we're getting some leak through there from the field, so try and mute the phone. And the other thing you can see there is metam sodium. So one of the things you can do in this case is you can say, well, maybe this is a fumigant exposure. Maybe she's getting exposed as a fumigant. You could ask her some questions, and if you really know your pesticides, you could ask her, is there any smell that you notice when this happens? Next slide, please. Now, chloropicrin is a very, very irritating chemical. In fact, it's used as a warning chemical in methyl bromide applications. But metam sodium is, when it's exposed to water, converts to methyl isothiocyanate. And methyl isothiocyanate just so happens to be the thing that makes horseradish hot. And so you could ask her, if you really know your pesticides, does it smell like horseradish? And she might say, yeah, it sort of smells like, well, it smells like wasabi, which a lot of people would recognize. So that might be a tip-off for you. But you could also call your extension agent and ask, well, what would they be spraying at this point in time on a potato field at this time of the year? And metam sodium would be one thing that they would use, and certainly in eastern Washington they use it very heavily in potato fields. So you can get the label, you can look it up online if you want and pull it down, take a look at it, and on that label you'll have a lot of pretty valuable information. It tells you about the chemicals itself, it tells you about the symptoms that the people will present with. Go ahead to the next slide. It'll tell you about personal protective equipment that's usually used in these cases. Go ahead, next slide. And it'll even tell you about margins, how far away a person is supposed to be when a pesticide is applied, how far from buildings, etc. Well, let's go to the next slide, and this will show you how this stuff is actually applied. They do it through chemigation, and this is a center pivot irrigation operation on a potato field. And so metam is actually put in to the water as the chemigation, as the irrigation happens, and that causes the activation of the metam sodium. Now they're moving to a newer technology where they're actually injecting, and that's decreased a lot of the off-drift exposure. But metam sodium was one of those chemicals that did cause a fair bit of off-site drift, and if it's near residential areas, there was a fair bit of complaints about that. Next slide, please. So here you can look up the pesticide products themselves. Use the index to just look up metam sodium. Next slide. And there it is. And you can go to metam sodium and read about it. Next slide. And it'll tell you a fair bit about how it's used and what it does. Any questions at this point? Here's the actual metam sodium. Its toxicology is described there, treatment, etc. Treatment is really just decontamination and fresh air. Next slide. So let's do one more case here at least. Young lady comes into you and she's complaining of a few symptoms. She says that she's, go ahead. She's a 26-year-old female. She's reporting nausea, lightheadedness, and fatigue. She complains of tinglings in her fingers and lips. This began at noon, worsened until coming in. She's not pregnant, doesn't have any meds, and previously healthy, speaks only Spanish. Now I think with some of you, you've seen this before because I included this in a previous presentation. Go ahead to the next slide. So you've got a couple rather non-specific symptoms here. You ask her history. She says she's been working in a cabbage field all day. The field was wet with dew and her pants got wet up to her knees. Her sleeves got wet up to her elbows. This is modeled after an exposure that happened in Idaho with a chemical that had been sprayed on a field. There's generally a re-entry period which is required after the application of a chemical to an agricultural field, and that period is usually long enough at a minimum for the chemical to dry. But oftentimes when people arrive in the morning, the field's going to be wet because of dew anyway, and so they might not even recognize that the chemical's been sprayed. In the episode in Idaho, it turns out that the field had been sprayed actually at 3 a.m. By an aerial sprayer, and he did not notify the supervisor of the work team that the field had been sprayed. And of course, he wasn't on the ground and didn't post it, and as a result, people went in. But this is the same kind of thing that could easily happen in any kind of a row crop like this. In this case, we're talking about cabbage, in which some of these chemicals are used. Go ahead, next slide. So let's focus a little bit on pyrethroids, because in this case we're talking about pyrethroids. Pyrethroids have largely come to replace most of the organophosphates in agriculture. There's a few organophosphates still out there. There's still a fair bit of carbamates out there, but pyrethroids have largely replaced a lot of the organophosphates in applications. Now they come originally from chrysanthemum, and in the past, because pyrethrin came from chrysanthemum, you could see allergies related to it, but with pyrethroids, allergies are quite uncommon. The chemical was modified. That's why it's called an oid rather than the actual native chemical, and it has more environmental stability than the pyrethrins did. And there's two classes of the chemical. One is much more toxic than the other. The cyano groups tend to be more toxic and more likely to cause seizures if taken in large enough doses. It would be extremely unusual for a dermal exposure to lead to severe toxicity in pyrethroids, because those are just generally not that toxic compared to, say, the organophosphates. And in general, the symptomatology is a nuisance, certainly, but not life-threatening in most cases. Go ahead to the next slide, please. What pyrethroids do is they act very similar to the organochlorines. The organochlorines like DDT and heptachlor and chlordane, they actually work by interfering with sodium channel flux across the membrane, and they cause destabilization of normally stable tissue and spontaneous discharge in neurons. That explains the paresthesias and sometimes the tremor and sometimes seizures if they're bad enough because of this uncontrolled discharging. That tingling and burning of the mucous membranes and extremities is very characteristic of a pyrethroid overexposure, and oftentimes some nausea, vomiting, and dizziness is seen at the same time if the exposure is severe enough. Next slide, please. So treatment of pyrethroids, we don't have any antidote, as we don't for most chemicals, most pesticidal chemicals. The main thing is to stop exposure and decontaminate. So you want to be aggressive in getting the person decontaminated. If seizures are present, you want to control them. You definitely do not want to use atropine in a pyrethroid overexposure. You're probably only going to do harm if you do. So you want to make that distinction between a pyrethroid and an organophosphate and carbamate, because you don't want to use atropine in this case. Vitamin E oil is said to be helpful with that annoying tingling and numbness. And the one thing you got to remember is tingling and numbness is a pretty characteristic presentation of hyperventilation syndrome. So keep an eye, and when a person comes in with that kind of complaint and there's a possibility this might be a pesticide, you want to see, is this person hyperventilating because they're excited about some exposure or they're afraid, or are they in fact perceiving this as a real abnormality in the as a result of the exposure. Next slide, please. So what we do in suspected pesticide exposures, this is sort of the chain of things we want to do, is we want to collect the information on the pesticide as much as we can get. Oftentimes it's not readily available because you can't, but if you can't talk to anybody who knows about it, the worker rarely will know about it unless they're actually an applicator. But you can sometimes call back to the farm and find out, or sometimes you can call the extension service and ask them for some help with the information on the chemical that might have been used. Collect evidence of contamination in order to laboratory tests that are, if available. Obviously consult with appropriate specialists if you have them accessible to you. NPIC is a good source. NPIC is the National Pesticide Information Center, and you can call that number and get some information from NPIC. That's run out of Oregon State University. They're very helpful. You should schedule and follow up with the patient and report a pesticide incident if that's what it is, and consider, is it a work-related condition, and is this a worker comp case, and make sure you're filling out the appropriate information. Next slide. I'm going to go over a couple, we're getting close to the end of the talk, so I'm going to go over a couple very, very unique signs and symptoms that I think are so characteristic that if you see them, there's something you should really be thinking about. Can we go back there? Yeah, good. So meiosis, we've already talked about meiosis, that pupillary constriction that's very characteristic of a cholinergic inhibitor. Acral and perioral paresthesia is very characteristic of a acute pyrethroid exposure. Of course, peripheral neuropathy is also something you see in chronic arsenic poisoning. So that's one of the other things you could see it in, but that's a chronic condition and not an acute condition, and will also usually be associated with the other characteristic findings of arsenic overexposure, which is hyperkeratosis of the palms and feet. Another pretty characteristic abnormality that's rather unique to pesticides is hypermetabolism, and that happens with a couple of chemicals, including wood preservatives. And some of the older pesticides are no longer on the market that you don't have to worry too much about anymore. But those were one of the characteristics that you saw in some of the older chemicals. But today there's still some wood preservatives, phenol-based wood preservatives that can cause hypermetabolism if sufficient exposure happens. Hair loss, now that's not something that you're usually going to see unless a person might be working in a military operation, and that's because thallium, which is a very effective rat poison, is one of the things that causes hair loss, and you're not regularly going to see that because it doesn't happen very often. If you start seeing hair loss and you think you're seeing thallium toxicity, you should start talking to the police, I think, more often than not. Peripheral neuropathy, as I mentioned, arsenic can cause peripheral neuropathy. Organophosphates, excuse me, organophosphates are well known for causing a peripheral neuropathy, but it's primarily a motor neuropathy and not a sensory neuropathy. But it's one of the classic late presentations of certain organophosphate pesticides. Not all by any means, but some. And one still on the market, which is chlorpyrifos, is known to create a peripheral neuropathy as a late finding if sufficient exposure happens. So skin burn and loss of fingernails, this is pretty characteristic of paraquat. Paraquat is a herbicide. It's a contact herbicide. It's still used in the United States relatively widely. And it's a very irritating chemical, so it does cause a skin burn if it's in the concentrate form. And loss of fingernails is one of the things you see in folks who use this stuff regularly. Next slide, please. Seizures are something you see sometimes in organochlorine overexposure. We don't have a lot of organochlorines on the market still. There's a few that are still permitted for fire ant control. You can see it in late-stage organophosphate, fipronil, which is an ant poison. It's an ant usually used in ant bait. And then DEET, in large enough concentrations, particularly in children, DEET is the insect repellent that can cause seizures as well. Next slide, please. Or click. Metabolic acidosis, boric acid. Boric acid is sometimes used for controlling cockroaches, and herbicides, glyphosate, is one of the things that can cause that if ingested. Rarely through dermal exposure would you see enough absorption to have metabolic acidosis. This is generally after an ingestion. Next slide, please. Cardiac arrhythmias, torsade de Plant, can happen with severe bradycardia in organophosphate toxicity, a pretty tough condition to treat, and oftentimes fatal if they get to this point, but that's one of the abnormalities in cardiac arrhythmias that you can see. Next slide, please. Bloody diarrhea, we're back to arsenic and thallium, generally not very commonly used, sometimes used as rat poison in institutional areas where thallium is still used, and that might be in military complexes or overseas. Pulmonary edema can happen with organophosphates and carbamates because of the excessive production of secretions, and it goes on to develop pulmonary edema. Altered mental status in many different chemicals. OPs, certainly, carbamates and fumigants are very common. Methyl bromide, one of the fumigants used in strawberries, is very well known for that particular problem. Next slide, please. And hypermetabolism, these are the two chemicals I was talking about. Dynaseb is that chemical that's no longer available on the market. Characteristic of Dynaseb is people who are exposed to it turn yellow. Their skin turns yellow. It dyes the skin yellow. Pentachlorophenol is that wood preservative, and the phenol wood preservatives like that that can cause a hypermetabolism. And that can be absorbed through the skin relatively well. Next slide, please.
Okay, so does anyone have any questions for Matt before I talk about some of our resources? Okay, so I just wanted to let you all know that MCN has several pesticide-related resources. I think first and foremost, again, the recognition and management of pesticide poisonings. Almost everything that we talked about is discussed in the book, and there's also lists and also a whole chapter on making the diagnosis. So if you don't have this book, we really recommend that you get it. It's free, and Carrie Brennan from our office will be happy to help you if you have any issues getting it from the EPA. The other things that we have for you is that we have clinical protocols and policies for dealing with an acutely poisoned patient, and I'll be following up just to make sure that we can adapt it accordingly for each of your health centers. We have on our website, we have the reporting page, and you can find out. So we're talking about 3 different states today. There's folks from North Dakota, there's folks from Minnesota, folks from Illinois, where it is recommended for you to report or what to do in case of a pesticide exposure and what the laws are in your state. So all of these things are neatly packaged thanks to our Carrie Brennan in our office and Jennifer Sane in California, and they come to you in an email with all of the links right there for you, so you don't have to work too hard. So I just wanted to let you know that they're your resources, and they're on our website, but they're also packaged in this little email that will be coming to you shortly. And of course, you can contact either one of us anytime.
Happy to take any call.
Yeah, that's great. Matt would be happy to take any calls. And then, of course, we need to get your feedback, whether you're getting a CME or CNE for this course or not. We really welcome your feedback. We take these evaluations pretty seriously. Jillian, I'm not sure how it works. Maybe you could explain how the link gets to them.
Yeah, so the link, as soon as this meeting closes, the link will send automatically, and it should open up on your desktop. If you're not at your computer right now, or there are multiple people there, the link will also be in the email that will go out to you in a couple hours with all of the resources and everything else. So you can also fill it out later on.
Okay, and I believe, if there are any questions, I believe that's the end of our presentation. You can unmute and ask any questions you want. You have a minute or two left.
Just our thanks, Amy. This is Susan Bauer and Dr. Gavigan. We're going to have to sign up to get onto another call, but this is really terrific. My only question is, I think Jillian said that you all are recording this. Will we or other providers and staff that didn't have the opportunity to be on this live broadcast, will there be an opportunity for them to access that archived?
Yeah, I will follow up with you, Susan, and because of some of the scheduling issues, I'm hoping to actually get you a live one if we have enough providers that are from your end that want to listen to this. So either archive or live, we'll talk about it.
Okay, that sounds great. Thank you.
Okay, thank you all for your attention.
I have a question, if you don't mind.
Sure.
Okay, I wasn't able to do it on the computer because my computer didn't log on to the link, but I listened to everything, and so that link that you said you were going to be sending over to everybody, how can I get access to it? Can you email it to me?
Yes, the email, as long as you registered for this, the email that will be coming your way will have the entire archive presentation. It'll have a PDF of all the slides, as well as all of the resources.
Okay, that's great. Okay, thank you.
Great.
Okay, thanks everybody. I'm going to go ahead and end the meeting, and the evaluation link should pop up if all goes well. Thank you.